On to our afternoon keynote speaker. It is with great pleasure that I am delighted to introduce our afternoon speaker who traveled to join us from Vanderbilt University. Consuelo Wilkins is the Executive Director of the Meharry-Vanderbilt Alliance and Associate Professor of Medicine at both Vanderbilt University Medical Center and Meharry Medical College. In addition, she is Director of the Engagement Core of the All of Us Research Program, which is really the new precision health or precision medicine initiative that was started by the NIH. In her role, Dr. Wilkins oversees initiatives that meaningfully engage research participants in the governance, oversight, implementation, and dissemination of the program. She has pioneered methods of stakeholder engagement that involve community members and patients in all stages of biomedical and health research. She also is currently a principal investigator of two NIH-funded centers, the Vanderbilt Miami Meharry Center of Excellence in Precision Medicine and Population Health, which focuses on decreasing disparities among African Americans and Latinos using precision medicine, and the Vanderbilt Recruitment Innovation Center, which is a national center dedicated to enhancing recruitment and retention in clinical trials and translational research. Today, she is joining us and will share with us on the topic of equity, engagement, and the promise of precision medicine. Please join me in welcoming Dr. Wilkins.
It is a real pleasure for me to be here today and experience your inaugural symposium. I feel like I'm getting some feedback. Is it just me? You're okay? Okay. I have enjoyed learning about the great work that you all are doing and really appreciate the emphasis that I'm seeing on the real transdisciplinary work that you're doing, involving all the different schools and disciplines. And also the explicit focus on implementation. So I'm going to share some of the work that we've been doing, but also I'm going to start out with some of the challenges that I see as the field of precision medicine, precision health really starts to take light. Key points I want to make sure we discuss are around the potential for genomics and precision medicine to have an impact on health disparities and health equity. And I think in order to do this, we really have to recognize the need for increasing the representation of the populations that are being included in precision medicine. And I'm seeing some of that happen already. It is going to be challenging, and so I'll share some of our lessons learned and things that we're doing both in Nashville, but also broadly in the All of Us Research Program. This really requires us to think differently about research in general, how we approach people, how we think about race, ethnicity, ancestry is something new. Some of the discussions that we're having in our center around what race means, what ancestry means, and unfortunately some at times challenging discussions about when we should tell people what their race is based on genetic ancestry markers. So if any of you had that experience, you can imagine how challenging those discussions can be. But I think in general, this is an important opportunity for us in the health professions and biomedical research to truly advance the field and make sure that whatever we're developing in precision medicine doesn't widen the disparities. And this is an opportunity for us to, in some ways, push the reset button. So many of you are familiar with the slide on the screen. It is from the Robert Wood Johnson Foundation. And for those of you who know this work, also know that there used to be a popular slide where there were three people sort of trying to look over the fence at a baseball game. And on different carts. And so this is an updated version where the emphasis is really thinking about what people need, not giving everyone the same thing. So if we're focusing on equality, then everybody gets the same thing. But if we're focusing on equity, everyone has a fair and just opportunity to be healthy. which means that we are giving them the kind of cycle that's most relevant or useful for their needs and preferences. This is how I see precision or medicine, precision health, personalized medicine. If we're really providing people the right preventative options, diagnostic tools, treatments based on not just their genes, their culture, their lifestyle, their preferences, their educational attainment, where they live, then that is equity. And so for my colleagues who are from more of a public health background, and when they think about precision medicine, they think, this is not what we should be focusing on. We need to spend our time and efforts in different places. I think that if we're really doing precision health, precision medicine, we're finding better ways to bring in all of the different data sources, and again, not just focusing on genetics and genomics. Of course, genetics and genomics is a huge piece of that, and historically, we've not done well. The really large databases that are commonly used for discovery don't include enough minorities. And so this is also a slide or a paper that's often cited where we're showing over the last decade really some progress in making sure that there's some inclusion of racial and ethnic minorities in the databases, but we're still very far from representing the demographics of the country. So 2009, 96% of these large databases were people of European ancestry. 2016, we're doing a little bit better with 81% of them being, so 19% of them being racial and ethnic minorities, but that gain really has been mostly in people of Asian ancestry. So still people who are Hispanic, Latino, African descent, the groups that have perhaps the most genetic diversity are absent in many of these large databases. This is really, I think, when I think about the research that's being funded with federal dollars, I think it's really unacceptable for us to continue to fund research that's being conducted in these populations and these databases that are not representative, especially when we already know. If you look through the literature, there are plenty of reports, pharmacological reports, FDA cited papers that show differences in genetic variants that are more common among people of African descent. And if you look at this table, these are for drugs that are commonly used in conditions where there are disparities like asthma and schizophrenia. So we already know that there are these genetic differences and higher frequencies among people of African descent where there may be an increased risk for side effects or for the drugs not working, yet we continue to prescribe them. We have very little primary research in this area, and there are very few drugs, discovery pathways that are really focused on making sure that we acknowledge these differences. Of course, it's easy for me to say we need to do better and that we need to include more racial and ethnic minorities in research, but the reality is that it's a challenge for us to get them involved. And that's for many reasons. Certainly, there are historical research abuses, but specifically related to genetics and genomics, eugenics and discrimination that are still happening today. There are other issues that minorities are more concerned about often as it relates to DNA being tied to economic losses, also being associated with the criminal justice system and paternity. And certainly for people who are American Indian Native populations are often concerned about that what we find or what we think we've found related to their DNA and genetics contradicts their cultural and ancestral beliefs. If I've learned nothing else in this space, I will say that as scientists, we are insensitive to the cultural concerns that people have. So I hear often, and a number of speakers today talked about privacy and protections. And if you say to someone who's from a background, a population where they're always in the minority, they're always experiencing the worst outcomes, that don't worry about it. The risk of your data being breached is very small. The risk that we'll find that something bad will happen is 1 in a million. They don't hear that as a small risk. They hear that, oh, it'll just be me and my community yet again experiencing these. And so I think we have to make sure that we understand how to acknowledge that they have valid concerns because of the historical abuses, and historical meaning, last week, that we continue to have these, research abuses that disproportionately impact minorities. So I didn't think I had enough time to really get through all the things I wanted to talk about and show pictures of some of the pictures that I like to do to engage the audience. But I have a set of pictures where I show different people and I cover their faces and I ask you to tell me, what their race and ethnicity is based on, their outward appearance. And then I take the sort of the eye covers off, and the person that you said was a blonde white woman is Beyonce. So, it gets to the fact that what we consider race and ethnicity in the U.S., what we consider race in particular in the U.S., is really about an outward appearance. It's about people's skin color, the size of their nose, the curliness of their hair, the fullness of their lips. These are physical attributes that have really no biological basis. So thinking about that from the standpoint of race and health means that people who experience disparities just due to race, it's often not due to genetics. It's probably due to social cultural things, including discrimination. Now, of course, in the U.S., people who are racial and ethnic minorities, in particular people who are of African descent, African Americans, descendants of slaves, and people who are Hispanic, Latino, the race is often a proxy for other things. So lower educational attainment, fewer economic opportunities, and how we disentangle that in the setting of all these other things that we need to understand about health can be very challenging. I won't go through all of the definitions here, but just want to again point out one of the challenges we have as we're bringing together health services researchers and social scientists and geneticists is that on one side, people who are used to working in genetics and genomics conflate ancestry with race. And so trying to make sure that you understand what race means and having the opportunity to self-identify is really important. If you missed this issue of National Geographic, I think it's extremely well done. It talks about really that race is not, there's no scientific basis for race. So the picture of the two young ladies on the left, they are twins. And so if you look at them again from an outward appearance, you can imagine that they probably experience life in a very different way. The grid of the 6 individuals at the top, they all have the same percentage of ancestry mix based on their DNA. But they, again, look perhaps quite different. I think the thing that the National Geographic did well here was that they actually had an outside group come in and take a look at their history of their journals, their issues for many years, and they acknowledged that their coverage had actually been perhaps racist. And if you are familiar with National Geographic, the beautiful pictures and the ethnography and anthropology components are often very well done, but they acknowledge that some of the language that they used was probably hyper focused on some of their physical attributes and some things that they experienced. So I think it's a nice lesson to sort of see them acknowledge that they were going to now move forward with these periodic external reviews to make sure that there was some accountability for them. And then this story is also there where I've mentioned, and this is still up for debate in some places. People will still try and push that there is a biological basis for race, but I think there are genetic reasons that you have darker skin or fuller nose, but there's no common thread that contributes to how we identify race, especially in the U.S. And I think it's important that we acknowledge that in the U.S., race and ethnicity, the way that we even categorize race and ethnicity is for the intents of oppression. So historically, people who are descendants of slaves, if you had one drop of black blood, you were considered black. It didn't matter what your external appearance looked like in some ways. And it was the opposite for American Indians. So your rights and opportunities were lost if you actually were if you had even one drop of blood from another race or ethnicity. Up until 2020 census, as it was planned, there was going to be still 2 questions for race and ethnicity. It looks like that's probably still going to be the case. So that race is one question and ethnicity is a separate question. That really means that we only acknowledge 2 ethnicities. Either you're Hispanic or you're not. No other ethnicities are acknowledged the way that the OMB criteria are. And so what does that say about us wanting to actually identify only people who are Hispanic ethnicity? What is the reason for that? What's the rationale? So this is from data that we collected at Vanderbilt a few years ago as we were starting to launch a number of our precision medicine initiatives. We really wanted to make sure that we could fully understand how to begin to think about implementation. So we asked questions of a little over 1,200 patients in our patient portal. We wanted to know how familiar they were with some common genetic terms, maybe not so common. Pharmacogenomics, genetic testing, and precision medicine. I was actually shocked that more people were familiar with the term pharmacogenomics than they were with precision medicine, but certainly it is a newer term. But we saw that there were racial and ethnic differences in people's familiarity with these terms. So as we think about, again, this new field of health research and medicine, how we implement the findings, how we communicate this is going to depend on the genetic and precision genomic health literacy of individuals, which also is highly dependent on numeracy. So if you need to communicate these complex risks of things to individuals, we have to start to think about their numeracy level. This is a list of challenges and recommendations, and so as you're starting to build and expand your programs, I think this is a great place to go to start to think about what are you doing as a program to address some of these challenges around diversity, getting diverse populations and doing health disparities research as it relates to precision medicine. We certainly need to enhance the workforce diversity for science and medicine in general, but in the field of genetics and genomics in particular. I've heard about some of the efforts around engagement, and I think that's really important. Making sure that we are holding each other accountable for the lack of diversity in these cohorts and samples, raising the expectations at all levels. I think that needs to be incorporated into the scientific review process somehow. And I think we also have to acknowledge that if we want to promote this kind of work, we have to recognize that some of the population sample sizes are going to be smaller, and this work still needs to be published with the limitations acknowledged. There are analytic challenges, and we need new tools to make sure that we understand the admixture that is more prevalent among minorities. So I'll shift now to some of the work that we're doing in Nashville and some of our regional and national programs. There are 5 centers funded by primarily the National Institute of Minority Health and Health Disparities that focus on precision medicine and health disparities. These were awarded in 2016, and I am one of the principal investigators of the one that is Vanderbilt, Meharry, and the University of Miami. So our collaborative is one where we focus on health disparities in African Americans and Hispanics, Latinos. I am, again, one of the principal investigators with Nancy Cox, who leads our our Vanderbilt Genetics Institute. Maria Lima is the dean of the graduate school at Meharry, and Roy Weiss is the chair of internal medicine at Miami. And then these are the 4 cores. It looks like implementation got cut off a little bit there, but there are 2 cores that are required for all the centers, and that's the consortium and the implementation core. And we decided to add 2 additional cores that focus on training and mentoring. So if we're really going to increase our opportunities for discovery related to disparities, equity, and precision medicine, how do we begin to cross-pollinate, train, work together across these very different disciplines? People who've traditionally done research in health disparities are trained differently than those who have traditionally done research in genetics and genomics. And so bringing together these groups, but also how do we expand the databases, resources that we have available that include minorities. So at Vanderbilt, I know a number of you are aware of BioView. That is our biobank that's connected to our electronic health records. We have now over, I believe, 260,000 people who have DNA been genotyped in some way in that database, and again, it's connected to the EHR. So we have prioritized over the last 2 years genotyping minorities. So because we're currently at a time where we can't genotype every single sample that we get immediately, we've prioritized, and so about half of those that we are genotyping on a regular basis now are minorities, so that we can increase that. And we're trying to expand the capacity and number of individuals who are genotyped at both Meharry and Miami. So key focus of our work is this transdisciplinary, these transdisciplinary approaches. We recently did an interview with Nancy Cox, who's a geneticist, and Hector Meyer, who is a social scientist, and had some of their had a discussion about their preconceptions about what their perspectives were about how to do research in minority populations and the importance of race and ancestry, et cetera. So I'm happy to share share that after we finish the editing for that. But we also focus on making sure that we're developing disease-agnostic tools, and so creating new ways of thinking about health and precision health in minorities that can be used across different diseases. So one is a statistical modeling where we're looking at data in communities and pulling in contextual data, information about education, mean educational attainment in the community, whether or not people live in census tracts where there's more or less home ownership, and using some of that to actually predict risks for things like cervical cancer. So that kind of modeling we believe will be able to be used in different diseases. This is us working in Miami. So the one benefit of having a partnership with the University of Miami is when we have our yearly meetings, we can rotate, and so we're in Miami in the winter, and we're meeting outside, and we're actually working. In case anyone asks. Our training and mentoring core has really been phenomenal, and it's great to see your emphasis here on scholars. We have been able to provide training opportunities and mentoring where our young scholars have mentors from a health disparities researcher and a traditionally genetics or precision medicine researcher to help move their work forward and advise and guide them. We have 2 of our mentees that have received K awards, and which is great. We've only been working for 3 years, and a couple more that are in the pipeline. So we're really excited about this work. One of our scholars actually led this work, and I'll apologize to her that somehow her name didn't make it onto the slide. But Kiara Atkins is a Meharry graduate student and working in the Vanderbilt lab with Nancy Cox and Leah Davidson. Looked at about 30,000 African Americans in our BioView database. And what she did was modeling that took whether people were self-identified as African American, so that's the pink circle, and then those that based on the genetic ancestry, their principal component 1 primarily there. So when you pull those apart, if you look just at what it can be attributed to, the genetic ancestry, African ancestry, those conditions that are in the electronic health record are kidney disease, sickle cell anemia, and goiters. Of course, we wouldn't be surprised about the kidney disease and sickle cell disease because we know about APOL and sickle cell disease having genetic origins there. But if you look just at race, the 2 conditions that were closely associated with being African American are hypertension and fatigue. And so I think this is really important as we, again, begin to think about what's genetic versus what likely has some other social, environmental components associated with it. This is also work from BioView, where we look at people who are self-reported Hispanic, and then we look at the different components in their genetic ancestry. So again, showing that how people identify based on an ethnicity or race is different than genetic ancestry, and we have to understand that and really begin to include that, because I think there's an important reason for us to acknowledge both and include both, but not conflate them. So some of the work that we're doing is also focused on trust, and How do you measure trust? We have two different projects that are developing measures of trust. The reason that we're doing this work is because the existing tools that measure trust probably don't capture the most salient points for minorities. And why do we need to measure trust? So that we can know if we improved it, or we keep talking about doing things, engaging people, building trust, but we actually don't know if we're doing that because we're not measuring it, or at least we're not measuring it well. So in one of the projects we've been doing, focus groups with individuals who are African Americans, separately Latinos, Hispanics, and then separately whites, and then another group of whites who are low income, because we think that a lot of what people are experiencing is not just, again, due to an outward appearance, but social deprivation, economic lack of economic opportunities, and so that there are some commonalities there. We've found that there's some interesting emerging concepts that come from minorities. For those of you who do work, I know Karen and Tricia and others who work in these communities, often these don't surprise you, especially concerns about risk and harm. These, again, we often underappreciate people's concerns about risk of being in a study and the potential harms. One of the things that sort of has sparked a lot of debate for us is the difference between privacy and secrecy. There was a question earlier about, during the fireside chat, about who's doing privacy well, and I think what we don't fully understand yet, and maybe others do, is how people who are marginalized or vulnerable, especially when there have been these historical abuses, their risk perceptions and their aversions to risk are different. And part of that seems to be related to this concept of secrecy, that there's a belief that you're going to keep something from them or hide something, and that is intentional. It's not about a security or privacy breach. It's about a fundamental mistrust, distrust of the establishment. And how we account for that, I'm hoping that there's a way to do that with more oversight and inclusion of those groups in leadership roles, but it's really not, we're really not sure about that. We also, I think this is often underappreciated. We talk about groups not trusting us, and that really puts all of the blame and the onus on them to be more trusting, as opposed to, are we trustworthy? Are we, as researchers, research programs, doing things that are worthy of their trust? Are we communicating well with them? Are we making sure that we've considered what their priorities are, their needs are, and how we can best engage them? Another body of work that we're doing is focused on returning value. So this is a little bit of a spin on return of results, and Sachin may remember early on in the PMI pilot when we started to have these discussions about how do we return value to people, and thinking about not just, again, research results, but keeping them informed, other information. How can we actually make sure that we're engaging them and returning something? This is really important for minority communities, because we hear a lot of the concerns about the helicopter researchers and come take but never leave anything piece. And so how do we improve on that? So this is from a national survey that we did. It was published in Health Affairs earlier this year. We surveyed over 2,500 people. You can see the demographics there. We were intentional in trying to make sure that we had some geographic spread, but also age, education, and racial and ethnic minorities there. So we asked people to rate which things were most valuable to them. So we asked several different ways. One is, on a scale of 1 to 7, not at all valuable to extremely valuable. We had 9 different things. You're only seeing 4 of them here. Which are the most, how do you value these if we were returning this information to you? So basic information about you, lifestyle, genetics, information that would allow you to connect with others. We also asked about financial incentives, and then we asked, if you could only choose one, which would you choose? So when we asked them to rate the value of everything, pharmacogenomic results came out as the highest value. And then genetic information about a risk of a disease was just behind that. When we asked people to just choose one, they actually chose genetic risk of a disease first. So pharmacogenomics dropped out of that. And so what you're seeing here are the results based on educational attainment. So the yellow bars are genetic risk of a disease. So think about ACGME 59 is sort of how we described it. Every group except those who had a high school education or less most valued getting genetic results. And that group of people who had a high school education or less, not only wasn't number 2 either, it was really much lower. That group most valued connecting with others like me. So we're not really sure what that means. Does it mean that they're just smarter than us and think that genetics is, waste of time? Or are they missing something? So things that we think they have, support systems to make decisions, understanding of genetic information. I'm not sure that it's the latter because they still rated genetic information highly. When we ask them, each question individually. But this is something that we need to understand, and also, if we're returning results, have some flexibility in what we do. So if we design all of our programs to just return genetic results, then we shouldn't be surprised when we're missing a category of people because this is not something that they find valuable, or they're not staying in the studies. You may not be able to see the map very well, but still a sore spot for me is the map, where we had 49 states and Puerto Rico, but no one from Wyoming responded, so I'm really sad about that. Any of you from Wyoming, I'll be taking numbers and emails later to help with that. I think that's just a different way of looking at the data. So I'll finish up and hopefully have time for questions and tell you a little bit about the work we're doing with the All of Us research program. So I have the pleasure of overseeing the All of Us engagement core, which is really focused on engaging participants as partners in the governance and oversight of the program. Many of you are probably very familiar with All of Us. It was previously called the Precision Medicine Initiative. There are billions of your dollars being invested in this by NIH as this million-person program where we're collecting biospecimen, contextual data, participant-reported information, and it officially launched about a year ago, and as of last week, we now have 200,000 people who are enrolled and have consented to the program. We at Vanderbilt had the opportunity to have a leading role in this back in 2016 when the pilot was being developed, and we worked with Sachin and others here at in the pilot. So that was really fast-paced. It was one of these grants that was submitted. I think it was submitted. The announcement came just around Thanksgiving in 2015, and the grant went in, I think, December 23rd. And then we got a notice in late January that we needed to go defend our application because we were a finalist. So it's one of those that really had a really short turnaround time, and then we were expected to have results immediately. Right. So one of the things I was charged with doing was trying to get input from different populations to build the program. So I said, well, you know, there are 1 million people, lots of different groups, and I want to think about this from the standpoint of diversity, so people from different demographics that are often underrepresented, but also inclusivity. So if we're not intentional in how we design this, they won't have an opportunity to participate. So those traditionally underrepresented groups, racial and ethnic minorities, sexual gender minorities, people living in rural communities, but then inclusivity being people who are deaf, blind, limited mobility. And so I came up with these 16 different groups, and for those of you who are involved in community engagement, we're used to having to defend our work, but also people telling us we can't do all of that. So I said, these are the 16 different groups, and I was waiting for Josh Denny and Dan Roden to say, that's too many, that's ridiculous. And they didn't, so we got busy. So we actually, in a very short period of time, did what we call community engagement studios. They're roundtable sessions where we went around the country and on the ground elicited input into the Precision Medicine Initiative. And these are sort of how we operationalize those groups. So there's 16 different groups, but we did each group multiple times. And so, for example, we were in South Florida working with young adults who were LGBTQ. And then we were working with rural people in Tennessee, but also in South Dakota. We had some restrictions from NIH on where we could go because the program at the time hadn't been publicly announced, and so they didn't want a lot of questions as we were still building it. But in about 6 months, we did 77 of these in-person community engagement studios, a little over 650 people. Almost half of them were racial and ethnic minorities, about 12% were sexual and gender minorities, and that's the map of what it looks like. So that information actually was used to inform the program, the need for continued community engagement. One thing that was not included at the time, planned initially, was compensation. There was going to be no compensation at all. Based on the feedback we got, upon enrollment, people get $25 for completing the initial assessments. There were no plans for really on-the-ground engagement. People envisioned that all of this enrollment was going to happen virtually, digitally, and so we had a lot of influence in the program, and so I'm very proud of that. What the Engagement Corps does now is, again, we are responsible for integrating real participants. So these are people who are enrolled in the program. They have to have no other criteria than be participants to be considered. And we are embedding them you see the little ellipticals at the bottom. They are on the steering committee. So the steering committee for all of us includes the PIs of all the programs, NIH leaders, and we have 4 participants who are on that committee. That means that they have to attend the weekly meetings. We have to onboard them, prepare them, and make sure that they're able to meaningfully engage in this process. The executive committee is a smaller component of the steering committee. There are about 12 people on that, and 2 of them are participants. So they have a bigger voice in that setting and are very engaged and involved. We have individuals around the country who are participant ambassadors, and so we really have, it's so exciting to be able to do this because we have the opportunity not just to integrate them into these settings, but we're also looking for evidence of impact. So a common question that I get is, what's the difference between engagement and recruitment or participation? And recruitment means that your focus, your intent is to get the individual enrolled in the study. Engagement, the end point is you have input that's bidirectional, so you give something, you get something. If you just gave something, that's outreach, it's not engagement. You have to be able to get something from those individuals, and there needs to be evidence that you've included it either in your decision making, you've changed direction, you've acted on it in some way, and that is how we think about engagement. So it's not enough for us to identify these individuals, give them a title of being on the steering committee, but then not have any evidence that they've changed direction. So as part of this process, we have done an initial readiness survey of the entire consortium. So how do the principal investigators understand engagement? What are their thoughts and perspectives about how people can actually engage and what they can contribute, and we're tracking that. We're also interviewing and evaluating the leaders of each of the governance committees just to make sure that that we are able to track those things. These are more pictures. The one in the lower left corner is actually the participants giving a presentation to the All of Us Consortium. So these are, again, leaders of all of the principal investigators and NIH staff, NIH leaders as well, where we have deliberated on the kind of information that they want to see returned first from the program. And they're giving a presentation in Bethesda. I was sharing earlier with Vicki and Tricia that one of the benefits to doing this work is that we've been able to do things with our NIH grant dollars that people have told us we couldn't do before. Like, we have to pay to get all of these community members, participants to the meetings in DC, and so we insist that all of the arrangements are made in advance, that they incur no out-of-pocket costs, so that we have to pay for their travel, we give them an advance with their per diem, and we pay them for their participation for time that they're missing. And so this requires, there was also a discussion earlier about, the top-down and the way that pharmaceutical companies can really act quickly. Pharmaceutical companies are regularly engaging patients in their work, and they have the ability to, pay for things, get money out the door really quickly. We've had to actually rewrite some policies at Vanderbilt to be able to get some of this work done. So I'm happy to do that because I think it's so important if we're really going to be doing true, meaningful, and authentic engagement. So I'll end with, I think that, again, we have an incredible opportunity to really make sure that this new field of precision medicine, precision health, doesn't leave anyone behind. But more importantly, we have the opportunity to perhaps to address some disparities. And I think we can do that if we really bring the right people to the table, get a better understanding of how different disciplines think about these things, increase our ability to communicate effectively. And again, that means not blaming people for not understanding, but saying that we're not good at communicating. And I like the 3-minute talks and the push for being able to communicate better. I think we can't afford to miss the opportunity to really capture data outside of the clinical setting, and how we actually get information like data from Flint's water system, and where are the air quality monitors. What do we know about these different communities that's really impacting their health? And I think when we really get good, we'll know where the police response times are higher and what impact that might have in communities and stress and things like that. So I'm excited about it, if you couldn't tell. I think that this is really, again, a great opportunity to rethink our approach in many ways. And it's been a pleasure to learn all of the wonderful things you all are doing here. Thank you. Do I have time for questions? Are there questions?
Dr. Wilkins, so firstly, thank you very much for coming to Ann Arbor and the University of Michigan. If equality is that your sample size and all the subcategories reflect the community, equity presumably means that each minority group has sufficient sample size to answer the same question in different groups. So what has Vanderbilt done about overrepresenting minorities in your sample size in order that you have sufficient sample to actually make a meaningful data analysis? So how have you gone about this? How have you chosen the sample size? How have you implemented this as a strategy?
Great question. So I do think that sample size is important. I'm not sure I would actually parse it that simply, that you need sufficient numbers of each group to answer the question, because I actually think that's restricting us to assumptions that we've had for too long, that there are meaningful differences between those groups. So I think your sample size should really represent the disease or condition you're studying. So if you're studying diabetes, then what is the prevalence of diabetes in the population by these demographics? And so your sample size for that should include, so you should make sure that you have enough individuals from those different demographic groups to try and answer the question. I think if we have unlimited resources, of course, we can try and overrepresent some of those. But I think when you're overrepresenting, you're probably doing more basic discovery than just thinking about, you're looking for SNPs or other things, and not necessarily focus on a disease. So we are overrepresenting minorities who are being genotyped for BioView now. So there is the highest priority is for individuals who are of African descent, as we're doing whole genome sequencing. So that's one of the strategies that we're doing. But we also have, we're trying to put in place some checks and balances to make sure that we do have populations that represent the diseases that are being studied. So when we do our scientific review for our CTSA-funded pilots, that is a priority. For our precision medicine health disparities pilots, we actually have individuals from who are ethnographers, anthropologists, social scientists, as well as community members who are on that review panel. And we go through that checklist of making sure that the sample size is adequate to really address the question, but also considers the differences in the racial and ethnic minorities.
Hi, Chad Brummett, University of Michigan. I just want to say thank you. You're doing incredibly important work. I had a question. BioView is interesting in that you moved from huge numbers of samples in an opt-out consent now to an opt-in consent. And certainly you think a lot about informed consent and ethical informed consent with the work that you do. How are you processing the challenges or the ethics of using those samples collected during that opt-out phase, which was actually quite common during the time. I don't think, Vanderbilt was different in that way, but it certainly seems important given concerns. We certainly, I run the collections effort for Michigan Genomics Initiative, and African Americans are more likely to decline than Caucasians as we go to enroll them. And Express, actually, our team is educated on some of the problems from before, and we hear that from patients. So as you work through and process that change from an opt-out to an opt-in, what have you seen at Vanderbilt? And also, how do you view the use of that data from those years of opt-out?
Yeah, so great question. I actually, so we're not thinking about those as two different sets of data that's collected. So the data, and sorry, make sure you can hear me. So the data that was collected before we went from opt-out to opt-in, it's all together. How do I see them differently? So far we've not actually seen a difference in decline rates among minorities, but that's something that we're explicitly looking for. We have had a community advisory board for BioView for more than a decade. They're very active and engaged. It includes minorities, and so they have had input and oversight of that program. We actually have dollars that we give to our community advisory board to ask questions that we can use to try and answer concerns that they have, to develop informational flyers so that we can provide to the patients, and that was all while we were doing the opt-out. I think, the interesting question, and I really wish that we did more ethics, and so my ELSI colleagues, I push them to more think about societal implications from a community benefit standpoint than just the individual. And I think this is one of those areas where I'm not sure that people who are opting in are any more informed than the people who are opting out. So we are, there's that, we have a culture now of the, iPhone update, get to iTunes. There's a big document that pops up and you agree so you can move on to the next thing. So in the healthcare environment, in the clinical setting, we're asking people to consent to all kinds of things. Consent to send the information to the insurance company. Consent to, pay the bill if the insurance company. So the amount of information that we're providing, again, is so, so large, sometimes convoluted. So again, I'm not sure that people fully understand what they're consenting to or what they, again, they didn't opt out of. And I think that's a concern we should all have. Are we doing our very best to communicate to people, what we're doing with their data and information and how we're protecting it, and what are the potential long-term implications?
Questions?
Thanks, Dr. Wilkins. That was absolutely amazing and so educational. Is there any international context you can offer us for this word called diversity? I remember we were sitting at an NIH planning session and we reached out to our UK Biobank colleagues to say, how did you address diversity? And they said, well, you have to go to where the diverse populations are. We went to Scotland, and the entire room died laughing that the definition of diversity, if you're in London, is getting to Scotland. I come from India, where essentially 18 different states, cultures. What have we learned about diversity, how we define it in the U.S. compared to how other countries define it, and what can we learn from them potentially?
Yeah. That's a great question. I think, often when we say diversity, we're really talking about groups that are underrepresented. So if we're thinking from the standpoint of precision, I mean, we're all different. That's what diversity means. Diverse means different. Disparities, it means there are differences between these groups. And so, we all fit into different communities, different demographics. And so many of us are probably in some ways, depending on how we align, are underrepresented in some way, which is also a challenge, I think, in how all of us is considering diversity. So there are these 200,000 people now, and 80% of them are underrepresented in research. Like, is that possible? So, in that group are people who are over 65, people who live in rural communities, people who have, less than a high school education, people who are seen at a community health center, and racial and ethnic minorities, sexual gender minorities. So all of those people. So the majority are underrepresented in this group, I think, from that standpoint, it's great. But what does it really mean? I think it does probably mean that we've succeeded in making sure that we are not we're not all blue men or blue people. If that is our goal, then I think we're succeeding. One thing I didn't talk about is I mentioned that the current way OMB has the 2 questions. We spent a lot of time pushing NIH to actually have just 1 question for race and ethnicity, and that question does not mention race or ethnicity. It says which of these best describes you, and check as many as you'd like. So which of these best describes you? You can check African, Black, African American, you can check white, Hispanic, Latino, you can check all these things. And when you check it, you go to another screen, it branches. And so if you check your African American, then it branches and you can say you're Afro-Caribbean, you're Haitian, you're Nigerian, so you can go down that list. If you check that you're Asian, then you can check that you're Indian or Chinese or Korean. And so if we start to really look at the individuality of people at that level, then we're really all different. And I think for researchers, that is crazy. How are we going to put all these people, in these many different categories and make sense of it? But if we're really thinking about what we're looking for, so if you're looking for, SNPs, then does it matter how people identify? Does it matter if people identify as, man, woman, trans, queer? Like, does any of that matter if we're really looking for SNPs? So I'm not sure I know the answer to what is diversity, but I think if we're really going to be precise in pulling in all these data points, we have to accept the heterogeneity of people and our vast number of differences, and I think this is a great time to begin to think about things that way.
Okay, great. Thank you so much.
Thank you.